Hello everyone, welcome to my YouTube channel. Today we are going to talk about VTE, comprises of DVT and PE, part 2. Before we start, there is a disclaimer. This video is for informative purposes only. I am advising you to refer to the main textbook or sources that is used in each teaching center respectively. Thank you. Now let's begin. This video is a continuation of DVT and PE part 1. Let's start with blood investigation to confirm DVT. After history and physical examination, we proceed with 1. Full blood count, 2. Coagulation profile, 3. D-dimer. As explained before about D-dimer, D-dimer is a sensitive but not a specific test. D-dimer will be raised in a DVT patient for 7 days. A negative D-dimer, I can rule out DVT in patient with low to moderate risk and well score is less than 2. In positive D-dimer patient, it will be in a moderate to high risk of DVT, well score more than 2. I need to proceed to duplex ultrasonography. 4. Deficiency of factors, especially in hypercoagulable state. Blood that will be taken to check the status of protein C, protein S deficiency, antithrombin 3, factor V laden, antiphospholipid antibodies, homocysteine level. Usually indicated in patients who are less than 50 years old with family history of hypercoagulable state or familial deficiency, venous thrombosis in an unusual site, clinical setting whereby we notice there is a warfarin-induced skin necrosis. For radiological investigation, 5. Contrast venography is an invasive procedure. It is contraindicated or non-diagnostic in patient who has allergic reaction, contrast-induced DVT. The problem with contrast venography is that it has a technical difficulties with inter-observer variability and not readily available in certain centers. 6. Duplex ultrasonography. It combines ultrasound and Doppler, very high sensitivity and specificity for proximal vein thrombosis. Diagnosis can be difficult in venous thrombi proximal to inguinal ligament. Non-occluding thrombi is a bit difficult to detect. 7. CT venography. It is considered when thrombus extending into a superficial femoral vein at inguinal ligament, whereby primary diagnosis is iliofemoral deep vein thrombosis. We can combine with chest for suspected pulmonary embolism, PE. 8. MRI of lower limb. We can suggest in a second and third trimester of pregnancy to confirm presence of deep vein thrombosis. Complication of DVT can be divided into pulmonary embolism or B. Post-phlebitic syndrome. For pulmonary embolism, what happens is the clot dislodged, then travel to the lung via bloodstream through inferior vena cava. Embolism block the main artery of the lung or one of its branches. The symptoms, usually patient present with sudden onset of shortness of breath, chest pain of pleuritic in nature, worsened by bleeding, cough, hemoptysis. Physical examination, usually the signs are low-grade fever, cyanosis, increased respiratory rate, increased heart rate, the CVS, cardiovascular system, whereby patient will presented with left parasternal heave, loud P2, increase in jugular venous pressure, JVP. The lungs, usually we can hear a pleural rub. And ABG will show a low blood oxygen saturation. I am using well score for probability of acute pulmonary embolism. Easier for me to divide the risk factor and signs and symptoms during presentation. For risk factor, immobilization or surgery in previous 1 month, we can give 1.5 marks. History of DVT or pulmonary embolism can give 1.5 marks. Malignancy, treatment within 6 months or palliative in nature, I can give 1 mark. For sign and symptom, hemoptysis at 1 mark, tachycardia at 1.5 marks, clinical suspected DVT at 3 marks. Alternative diagnosis is less likely, PE, at 3 marks. So the traditional interpretation is score more than 6, high probability of pulmonary embolism. Score 2 to 6 is moderate probability of pulmonary embolism. Score less than 2, low probability of pulmonary embolism. Alternate interpretation is score more than 4, pulmonary embolism is likely. Consider diagnostic imaging. Score less than 4 or 4, pulmonary embolism is unlikely. D-dimer need to be done to rule out pulmonary embolism. For post-phlebitic syndrome, it is a late complication of deep vein thrombosis. What happens is the clot spans the valve, whereby causing incompetence of venous valve. There will be a blood pooling, then the venous destruction will occur. Symptoms of post-phlebitic syndrome are chronic leg pain, swelling, and heaviness. The signs are venous ulcer, purpura, eczematoid reaction, dermatitis, and pruritus. Okay, that's all for today. I am going to continue regarding management of DVT in the next video, part 3. Stay tuned. Thank you. Till we meet again. Bye.